Welcome to the Healthcare on the Move podcast, your gateway to understanding the future of clinical mobility. We bring together healthcare executives, IT leaders, and technology innovators to uncover the strategies that turn mobile technologies into powerful tools for patient care. Each episode uncovers the real-world insights that are reshaping healthcare technology. Now, here is your host, Myron Wallace.
Welcome to today's episode of Healthcare on the Move. I'm joined today by T-Mobile's healthcare team and my friend Jim Nation, who will be moderating today's discussion. Jim, I'm going to hand it over to you.
Thank you. It's great to be here. Welcome to the discussion on rural health care and transformation. I'm Jim Nation, your moderator. I'm part of the T-Mobile healthcare team, and I'm joined by an esteemed panel. Let's give everybody a moment to introduce themselves. Let's start with Dr. Alan Moore.
Yeah, Jim, hi. I'm looking forward to talking about how my subset of states, which are those east of the Mississippi from Miami to Maine, actually are going to be using or have asked to use $10 billion in 2026 funding from HHS to improve healthcare in rural areas of their state. So good to be with y'all and excited for the next half hour or so. Rich?
Thanks, Dr. Moore. Rich Garwood here. I'm Dr. Moore's counterpart on the West Coast, so I'll be providing some of that same demographic to the West Coast. So very happy to be here. Maggie?
Thanks, Rich. Maggie Duncan. I help focus on developing strategy for government segments within T-Mobile to help connect the dots to drive impact in business.
Great to have everybody here. Thank you, Maggie. Let's go ahead and get it kicked off with a question. Rich, why don't you tell us a little bit about the Rural Healthcare Transformation Program and what it means to the country?
Definitely. And a great place to start, Jim. Since we're going to be going state by state, I think it's really important to understand that from a national standpoint, this Rural Health Transformation Plan represents the most ambitious rural health investment that the government's ever had to date, right? And really what that is this was born out of the big, beautiful bill, Section 71401. And obviously there was a lot of things happening in that bill, but luckily for our rural patients, this funding came in and it's looking like it's going to be $10 billion a year nationally over the next 5 years. And then with the ability for that program to continue, so even spread potentially to 10 years. So again, the opportunity to improve access to care among dozens of things that these states have listed in their applications, it's a really great opportunity, and it's a really awesome opportunity for partners to kind of help serve the community as well.
Pretty exciting because the access to care, of course, being able to seal that gap, that's part of the triple aim. The triple aim, of course, being forefront of the Affordable Care Act. This is a critical moment for us in healthcare. But let's talk about how it's impacting us from coast to coast. Now, Rich, I know you represent the West Coast. Dr. Moore, tell us a little bit about what are you seeing? What feels like the most urgent need on the East Coast as it relates to healthcare sustainability?
Yeah, so the urgent need, I think, is keeping the doors open, right? I mean, there were 460-ish hospitals that were facing bankruptcy last year. There's about 380 that have been forecasted now. So the seventh item of the larger HHS grant opportunity, and there were 7 criteria that the states could petition money for, was the financial solvency. So how are states going to improve the solvency of rural healthcare providers? And I think, in order to stay afloat, you have to have patience. And if the practitioner and the patient are in remote spaces, that's okay, because there are funding opportunities to serve the patients via telehealth. And that's the first criteria for HHS. Of the 7, right, the first criteria was telehealth. How are you going to enable that? How are you going to do things that you haven't done before? Other areas of the 7 criteria talk about graduate medical education, training for practitioners, talk about advanced use of technology. There's plenty of opportunities there for states to get very creative even through transport means. I heard one of the representatives from the House in Tennessee this week talk about how can we use this funding. So we have a patient that's in a rural area in Tennessee that has a facility that has closed, and they need to travel to Memphis in order to get the services that they need. Then some of the states have provided for transportation as an option. So in working with partnerships for transportation, then the states can draw down that money to set up sustainable transportation means. This is not about funding Medicaid per se. This is about changing the way we deliver care. I think a lot of people are upset because the $50 billion over 5 years is 30% of what was taken away from Medicaid funding. But the reality is, if you keep doing what you're doing, you're going to keep getting what you're getting. And never has there been a better opportunity. Never has there been the tools that we've had for remote encounters and very creative uses of technology to distribute care differently. Now, to get back to your question, what do I see in my patch that may be different from what Rich sees? What I see are that my states on the East Coast are looking at the advanced use of technology. They're saying, where can we do AI coupled with remote patient monitoring? So how can we drain off another ounce of productivity with the devices that are in the field? They are assuming access is there, and they're layering on top of that. Rich, I'll let you contrast to that to maybe what you've seen in your patch.
Yeah, really well said, Dr. Moore. And I think a good way to think about this is that the destination for all 50 states is the same, but the routes are going to be very different, right? That destination is sustainable rural access, right? So how I'm seeing that differ is geography and population density is a huge one, right? Existing health system maturity, which you pointed out with the AI component, and then the degree of centralization versus decentralization, right? Think of the West Coast, especially some of these states we're going to talk about today, like Montana and Idaho, right? There's a degree of access that still needs to be built there that may not be as prevalent on the East Coast. So I think that's a really big part of some of these plans on the West Coast.
It's great information. So we are seeing a convergence right now of not only network need to support AI. You have various types of informatics, and we're seeing the technologies come together and emerge. Let's talk about what's happening in the rural care environment, though, because it's in many respects, rural care has been overlooked for a very long time. Creating access is something that healthcare organizations have been trying to do for a very long time. But let's talk a little bit about the need to create that access. We know that we need new workloads for AI. We know we have various informatics that we're going to be driving data like never before. But what happens when networks go down? When networks go down, we're trying to support these rural areas, but when we don't have network, what's the challenge? What's the limitation?
That's a great point, Jim. And I honestly want to bring it back to kind of what was happening in healthcare even before this emphasis on rural healthcare, right? Even pre-COVID and definitely post-COVID, right? What we're seeing is centralization being less and less, right? You're going into the physical hospital less, and you're going to clinics near your house that have specialties more and more. I kind of think of what's happening, or what the hope is to be happening with some of these dollars, is that ability to grow that network technologically, right? So as well, how do we make sure, to your point, that connectivity is a bar none throughout these rural areas, unlike it is today?
You know, Rich, you bring up a good point. I want to ask Maggie. Maggie, how are states deciding what various states need from coast to coast? How do states determine what new technologies are worth funding and what feels more experimental?
I think it's a combination of who their in-house technology experts are, as well as those that are able to influence from the outside. So if you think of different types of organizations, such as the National Association of State Technology Directors or the National Association of State CIOs. Those are, usually your technology folks at the state level, and influencing them on what is new or what is not what we would say, experimental, so to speak, that have proven track records, that other states that they know have also used them. That's really important to them because nobody wants to be first in state government. So they're looking to where the successes have already happened.
Well, so when we talk about the successes that have happened, there are three components, right? Because when it comes to healthcare, you have clinical, you have the operational, you have the financial. What are some of the challenges that we've seen over long periods of time, and as it relates, how much of that is actually infrastructure related? Because we mentioned earlier that we don't want science experiments. We want things that are proven out, but we also know there's a convergence of cloud, AI, various types of informatics. I'd like somebody to speak a little bit to how much of that is actually infrastructure and not necessarily and infrastructure improving and not necessarily a science project.
Yeah, let me try to take that. So I think in the remote counter space, we've ratcheted it up over the years, right? We've been at this telehealth progress now for 40 years, and it's just gotten better. We've gone from a voice call, we've gone to 12 lead EKGs that could be transmitted over a acoustic coupler, and now I'm showing my age. We've gone to store and forward, right? So you could take an image or a file and send that over, wait for a little bit, and then have a conversation with a provider. And now it's kind of assumed, right? So we're going to exchange this information in a remote setting. We're not having a same space encounter, but because the ubiquity in technology, we all have those FaceTime conversations with our grandkids or our parents, and we know it works. There's a certain amount of trust there that you have to have that the network is going to pull you through, and you're not going to lose things in translation. But I think because you've got the network and the access piece that has come up with the needs, now we're talking about equipping AI. We're talking about equipping the conversation to dictate the notes. So now our physicians don't necessarily have to spend as much time charting as they once did, because we've got this ambient listening in our conversation that's tracking this. And we believe that T priority will help that, but that's a product discussion, and I don't want to go there. But so I think that the technology has progressed at the same time as our level of expectation. Does that help, Jim?
That's great. Thank you for that. I'm curious, Rich, how are your states different, and what solutions are or facility? What solutions are more facility based? What are more virtual? What are mobile?
Yeah. I don't know. I'm pretty sure that this is going to be a main line, but something that I'm really proud of the states for bringing up is like no more is telehealth like something they want to pilot. It is a baseline infrastructure, right? Across every single one of these applications, right? And so I know we talked a little bit about differences, and we can get to some of those, but I really think like I'd love to just give it up to the states and everybody that applied there, right? Because it really is talking about this as something that's going to move this care forward at a very rapid pace, right? And when you talk about solutions, right, it's hey, how do we improve connectivity for these rural patients, right? There are different types of rural settings, right? Where I live in Seattle, a couple hours away from here, rural is at a couple thousand feet of elevation, hanging off a mountain cliff, right? Which is a little different than Dr. Moore's sense of rural, right? So there's challenges when it comes to that, and I think a lot of this kind of communication I'm hearing and reading, right? Hub and spoke models, right? Like I pointed out with the hospitals versus clinics. How are they going to take that to an infrastructure perspective? And I think again, it all starts with embracing telehealth as really what it truly can be, as well as remote patient monitoring, taking that the same way. And I see similar language in there as well.
I love the information you're sharing, but then I take this and I think about the investment that we're making across all of these states, and then I think about how are we measuring this, Maggie? How do government organizations measure these outcomes? Because obviously, if the investment's made, they're looking for outcomes. They're trying to support those clinical, operational, financial outcomes, but they also have to report this back to show success. Can you speak to how that works?
Yeah, so it looks like the way that majority of these states are setting them up is in a grant format in their applications. And when you do the grant, when you do that type of a format, you're really looking at having to measure your deliverables, or they'll call the money back. So that's going to be very important, is that you come up with realistic deliverables that are also in some form transformational. And that's going to be the
Oh,
key.
when you think about clawbacks, that's a terrifying term in healthcare. It,
Yes, it
it,
is.
Especially for some sales guys on the call.
right, right.
But it's terrifying from a government entity standpoint as well, when you've got a government body, that has developed this entire program around receiving these funds and then trying to execute the mission and the plan that they've put in place.
So guys, how are rural healthcare organizations trying to avoid those types of situations where financial penalties or clawbacks or metric expectations aren't met? How are healthcare organizations in your states? Can you speak a little bit to your states and talk about how are they planning to overcome some of those challenges and potential limitations? Dr. Moore?
Well, I think nothing succeeds like success, right? I mean, what a master of the obvious I am, but I think when you lead with telehealth, which is proven, right? We've got great metrics around telehealth that says it works in these certain settings, right? I mean, even HRSA opened up telehealth for group counseling during COVID, so we know that those metrics are going to satisfy the issuers of the dollars there from HHS. So there's no question there. I think when you start looking at things that may be a little longer, I think that you have to show progress. And Maggie, I'll defer to you on this one. If I have a project that is, in the case of the state of Mississippi, they're going to weigh heavily on building out their HI infrastructure. Not that they don't have other things in the pipeline, don't get me wrong, but that HIE infrastructure, so that a doctor in South Haven can talk to a doctor in Gulfport. They're all going to have the same record. The patient can go anywhere in the state and they'll be well connected, right? If I have that underway, I should be able to report a metric that says I am 40% into this project. We have shown success in proofs of concepts or pilots. Therefore, the remaining dollars that I have for this, I should be able to keep and continue to implement. Maggie, am I thinking right there that if I'm underway, I stand a better chance rather than just saying, I'm still planning to do X, I'm going through an RFP process, I'm talking to my stakeholders?
Well, those will be part of your timelines too. So when you really think about it, is that you have realistic timelines, because when you fall behind, to your point, being in the process is a whole lot better than saying we're still planning because we're trying to be perfect.
Yeah, I'd like to bring up here too is like this seems like a very appropriate place to talk about scale, right? I think this is a behemoth, right? And not saying the states aren't capable, but the ability to bring on capable partners, right, to help with that scale and to provide some of that tracking, Dr. Moore and Maggie, like we're talking about, I think it's going to be imperative, right?
Absolutely. Economy of scale is going to be significantly important. And a lot of these states are going to be looking to experts that are well versed in managing grants like this, grant programs like this. So they're going to be bringing in a third party consulting teams to advise them and to help manage the actual funds that are coming in.
So, Rich, you bring up a good point when we talk about scale, because one of the limitations is to scale is what happens when it breaks, right? Because we have to be able to we have to support these things through connectivity. Now, Dr. Moore, you brought up telehealth. You brought it up first, so that ball's in the air. Let me see if I can't get you guys to bat that ball around a little bit. When we think about the investment being made in telehealth, we've all seen this grow over many years, and of course it accelerated through the pandemic. As we've seen this growth, we've also seen the challenges and the horrors of not being able to connect with our loved ones at those final moments during the pandemic. But we're definitely in a position now today to move away from that. So when as Rich brings up scale, let's talk a little bit about what happens if we lose connectivity. What are the risks and limitations there, Dr. Moore?
Well, I think that you got to look at the day two support. You're exactly right, Jim, because everything's going to work right out of the box when you purchase it, right? Once you get past the initial setup, you can pretty much assume it's going to work well. I mean, there is the bathtub curve of usability there, and I think that you have to be on the lookout for day two support. I think that any of these things, and I look at what we're doing with data with RPM. So if you have an RPM device that is not connected 97% of the time, your number of data points you're going to get is going to be significantly smaller than the inverse, right? So I think that you have to consider, okay, I may not be connected, but did I get enough data from that RPM device when I was connected? Did I get 40 readings of my blood glucose levels, or did I get 4? So I don't think the disconnect here for data is awful. What I think is awful is when you don't have the ability to do some of these consults, right? Because each one of my states that I'm looking at, Tennessee, South Carolina, Connecticut, Wisconsin, those in my patch, they all have the opportunity to do consults at the edge. 3 of the 4 are looking at doing treat at the scene, not transport. So if you don't have the connectivity in the back of the squad car or in the ambulance or at the school, if that goes down, you now fall to the way that you did it in much the same way charting is done now, right? You've got ambient scribes and we're moving into that space. But when all else fails, you go back to, the pen and paper. So it's important that we have the connectivity. People rely on it. People assume it's going to be there. And as well as they should. We'd love to get to 6 Sigma reliability with our service, and I think that that's what people expect. But I also think that there are workarounds in the event that the connection is not there. You do what's been practiced, before we had the benefit of the wide ranging service that we've got.
Rich, you represent the other half of the country. Let me ask you the same. What are you seeing on your side of the country?
Yeah, I was going to compliment Dr. Moore on the comparison, because what I've been saying to myself, and I think is very, very obvious in some of this language on the West Coast, especially in some of these frontier states, is that if connectivity fails, care fails, right? We are further behind there. There are many places where people live out here where connectivity is still a really big issue. So again, I think from the overarching differences side, that's a big one to me, right? There are places where today we can still not get a pipe, like fiber piped to, right? Many places on the West Coast, right? And so I think that just brings up kind of for the overall statement on how important this infrastructure and like continued growth of telehealth and remote patient monitoring is just so needed on the West Coast.
It sounds like you're seeing a lot of the same things. There's very definite similarities in what you're saying. What are some of the What are some of the states that stand out? Rich, let's start with you. What are some of the states that stand out? What are you seeing in those states?
Yeah, and I think a big one for me from a differences perspective, right, is coordination first versus reach first, right? I think Dr. Moore, maybe you can speak to this, but a couple of your states are talking about these big portals they're going to build, right? So the exchange of information is going to be able to do that. I see zero of that across my states, right? Again, from a connectivity perspective, we are still building that, right? Whereas from your states, I'm seeing a lot more of kind of, hey, we've got everything set up. Let's figure out how to manage it proficiently, right? And ensure that those efficiencies are going to improve the care and access to our rural patients.
Yeah, right on. And I love the Connecticut exchange called Connie, which is pretty cool. There's some other states that's got some interesting names too. That one just stands out to me. That the AI enabled remote patient monitoring. Um, the I think the long pole in the tent for some of these are going to be the interconnection, right? I mean, you're talking about fire protocol, you're talking about IP standards. How do you get the inputs and the outputs to match, right? To get those bits and bytes to line up so that your address line in the record actually ends up with the address information and you're not, askew. I think that's really important. So good luck to them. I think that aiming to do some things with these HIEs where they are, wider in their coordination. So let's bring in the EMS. Let's bring in multiple providers. I love the work that Tennessee is doing. They're wanting to get an accurate bed count, and Pennsylvania is doing the same thing. They want to get an accurate bed count so the EMS knows where to take a patient. Let's read the ED data and find out if I have a choice of 3 emergency departments, which one do I want to go to based on, where the patient is in the care cycle and also where the patient is physically. I think that's important. So, I think that these states have taken on an enormous job of interconnecting these groups. I think it's going to be the long pole. But once we get there, it's going to be fantastic.
Yeah, the when I was reading some of your review of Tennessee specifically, it seems there it's almost EMS centric, right? Is how I was reading that. Whereas I think the rest of our states are trying to do a little bit of a multi-channel approach, but I'm very, very interested in that just because of all the awesome technology coming about these days that can support EMS much better than it has in the past.
I think about since we're talking about Tennessee, just a little north of me here. I think about some of the things that they have put forward in the request for the money. They got $206 million coming to them this year. They're launching into mental health first aid. A totally new term for me. Medical coordination centers that they're talking about building, closed loop referral systems. I think that's just brilliant. But to your point, Rich, a lot of EMS infrastructure works in that. Other ideas that I think are extending the boundary, I think are things like Connecticut's AI remote enabled patient monitoring. I think the real time bed utilization that they have provision there. Wisconsin is looking at doing AI documentation with their tools in same space and also in remote encounters. Service readiness from South Carolina. I love what they're doing. They're focused a little more on construction and building the foundation for care so that when this money runs out in 5 years, they will have built the foundation to support these other initiatives, and it can continue to sustain itself through normal reimbursement channel.
I was so surprised about how much construction was in South Carolina. And then you just kind of think of that and you're like, oh, geez, some of these areas have just been so underserved that they literally do not have the hospitals and clinics they need today to support those folks. And sometimes those folks are driving upwards of 4 or 5 hours to go get the care they need. And that's really exciting to think what year we're in. I was just very shocked and obviously excited for those folks to see that.
Yeah, absolutely. I love what Wisconsin's doing in supporting telehealth for veterans. They're also putting it in agriculture communities, non-traditional sites like schools and banks and libraries, so that you can go in and have a remote encounter if you don't have the access I love the digital inclusion for their state portal. So if you're a provider and you have data, is there going to be an opportunity for the patients to interconnect that with their mobile apps and their into the web? I think that's kind of where they're headed. Shout out big time to community health workers, right? I mean, we know that community health workers, maternal care, doulas, we know that those are where the rubber meets the road. When you have a community health worker out and they're checking blood pressure or they're looking at blood glucose, that really is reinforcing to everyone, hey, I'm here. We care about you. We want to make sure that you live a long and progressive life absent of disease, right? Isn't that what healthcare is all about? Absence of disease, whether it be physical or mental or behavioral, et cetera, et cetera. So I love the way they've stepped in. And without this funding, even though these are great ideas and Rich, I don't know if you agree or not, without this funding, some of these things probably would not have been launched, because even though you could make the business case for them, I don't know that you could find the funding on them.
You bring up a great point. And it's, again, it's a sad truth of like all of us working and supporting healthcare, right? Sometimes the money's just not there. And so the hope obviously is that's a thing of the past for the next 5 years, right? And I think a big thing is how do we set up that infrastructure that will last, right? Again, I know we've been frustrated with some of the things we've been hearing, right? Because again, this could be dollars for employment in some cases, right? But at the end of the time, I'm also pretty scared of that, because I don't want people getting laid off or fired when this money runs out, right? So how do we continue to extend that care and improve those people's jobs and have them reach more patients? That's what I'm really excited about.
What I've heard from you both is not just, and certainly you're all absolutely right. I mean, the lifeblood of healthcare is what's happening out in the field with the nurses and actually working and focusing on the patients. But what I'm also hearing is there are new innovative projects. Dr. Moore, you mentioned something that has never been done before. Rich, you've spoken about a couple projects that are, that are going to seal gaps and rebuild foundations under things that have been underfunded. But when I think about T-Mobile, we host data, secure data, and transport data. Data is the holy grail of healthcare. Now, being able to have this kind of infrastructure funding is tremendous. But we don't do that alone, right? We have partners like ProMobix. I want to get to some partnership discussion, but let's talk first about. Let me ask Maggie. Maggie, where do partnerships break down with procurement timelines, procedures as they relate to these types of partnerships when they're government funded?
I think not fully understanding the entire ecosystem of how it all works, thinking it's just one thing or the other, because they all build on one another. They're intricately involved. So if you think about it from the standpoint of, you need to know what agency owns this and how that's going to work, and then that helps you better understand what the processes will be, as well as the timelines and the alignment. Understanding all those things collectively, it sets you up for success overall. And then who the provider partners are, that's going to be imperatively important as well, because knowing who they are and knowing where T-Mobile may fit with their solutions and technology, or any other company that's trying to do the same thing, creating that crosswalk, that's where you move forward, because then you look like a true partner to the state agency as well.
As we move forward into the state funding program with partnerships, I'm gonna throw this out as a jump ball, and Myron, I'm hoping you'll jump in on the conversation here at this point. Let's talk about, where have we seen technology adopted successfully, and let's talk about Rich's point of scale. Let's talk about where we've seen struggle with scale. Personally, I've seen Dr. Moore mentioned earlier. He mentioned pre-hospital and patient transport. There's a project that people have been trying to copy from Houston, Texas for many, many years, and that's highly successful. Everybody's trying to figure out how to do telehealth during patient transport. But we've seen those things, that's been a widely successful project. But we've seen lots and lots of projects like that succeed. But we've also seen some others struggle with scale. To Rich's point. Let me just throw that up, and let's talk a little bit about where we've seen some of those successful adaptations of technology.
Yeah, great discussion, and really a great topic. The thing that's always amazed me about healthcare, and coming from where I began my career to where I'm at today, the most amazing thing that has always stood out is the fragmentation is so real across the enterprise. And I always call it an enterprise, call it a health system, call it what you want. But at the end of the day, they are an enterprise. They are deploying technology at enterprise scale and serviceability to not only provide connectivity, but the devices and the experience to the care teams. And one of the things that we've been spending a lot of time with at ProMobics is going shoulder to shoulder, elbow to elbow with the care teams and understanding what they're struggling with for access to technology. We were just at a customer site a few weeks back, and it was surreal to see that they're still using paper scheduling. They're still using 4 and 5 communication applications. So when you think about the unification of all these systems coming together, that's where I believe that this capability from not only T-Mobile on the network side, but then also the funding will provide a access pathway for healthcare environments to look at. We need to redesign the workflows around the technology and the actual care experience for the care teams. And that's really, in my opinion, where things have struggled to what you were describing, Jim. There's been a few use cases that's come out where they've highlighted the successes that they've had with technology. But the problem you also have is they've never had the technical capability. When you look at the larger academic institutions, they have the capability because they have the teams to employ the technology and sustain it. Whereas when you get into the rural markets, they have the same sets of challenges as everyone else does, but they don't have the teams to help them. And so much of the industry has really been about the fragmentation of implementing one thing for one outcome. And that in lies the problem that we're all facing right now. So hopefully, when we start peeling back the onion and looking at all these layers, we can say, okay, here's a path forward. Here's how we need to do systematic design and define the processes across that care continuum where technology is purpose built and purpose fit to the actual roles.
And then it becomes repeatable, right?
Exactly. And you can define the use cases at that point. You can point to the successes. You can actually point to the ROIs to say, we started here. Here's what we did to change the situation. And here's the outcome of these changes we implemented. I think it was Maggie, you mentioned about, technologies getting, deployed. And there's been a lot of recent news about the term pilot. Pilot is this mythical thing. It's a science project. It may work, it may not work, right? I mean, but this is what goes on, and they've become very allergic to that terminology. And how do you walk in and say, with specificity and defined outcomes, here are what you can expect to see, where we're not playing a science project? And that's where we need to get to as an industry. We're the stewards of this. And when you think about where T-Mobile sets, where ProMobic sets, and where all these device manufacturers set, we have the opportunity to really have a meaningful impact and change the outcome of this. And we need to make sure that we are not going down the path of putting up a bunch of information that's really not going to help the health systems at the end of the day.
That's why proof of concept is the better phrasing.
Yeah, it is.
Pilot, POC, you have in the clinical world in hospitals, you have evaluation. In pharmaceutical, you have clinical trials, right? But they're all important. But what I see is a convergence of technology, especially with cloud, AI, and 5G coming together to accelerate these things. Dr. Moore, can you tell us a little bit about some of the technologies where you're seeing success?
Well, I just want to echo what Myron was saying was that, when we get some data around this, even though there may not have been funding opportunity in the past because these were a little bit of a pilot opportunity, if we get the data around X, then we're more likely to fund Y in the future. So yeah, I appreciate that. I look at the states that I've got, and I think we were really centered on like 4 of them today, but I've looked over probably 25 or 30 of them and find that there's a lot of common needs around these states. Only 1 or 2 have not enumerated any thought around cyber or cloud, which surprises me. But by and large, the 95% that I have looked at, they talk about how this is going to be so evolutionary that the transformation to cloud and using digital technology has to be protected. And there's some things that we do from a network. Again, I don't want to go into product here, but there's some things that we do from a network perspective because our network is built differently that inherently locks down some of these applications. We have a client right now that was fined $198,000 by the OIG because a community health worker lost a pad. Well, we know that these states are leaning into care that's on wheels. We know that the community health worker is going to become even more important going forward. So therefore, the devices they have will need to absolutely have a great policy around it and also great execution to keep those records secure, so you don't drain off some of the funds that were going for transformation and put that into OIG funds. So I think that Louisiana is an interesting proposition. From a technology perspective, they're kind of mainstream and doing what a lot of other states are doing, but very few, Louisiana's one of them, but very few are actually setting up a long-term, what I would call trust fund for innovation. So they're peeling off a percentage of what they will get from HHS, and they will put that in the bank and say, we're going to let this grow. We're going to let this money sit here so that when somebody has an innovative idea, we can help fund that. And in that way, we don't have to worry about a pilot program being proven. We can help people who want to come out of the stage 0, develop a product and move further and faster. I like the telepreceptorship. I was blown away. Wisconsin and Connecticut talk about telepreceptorship. That's just fantastic. You have students in a rural part of the state who want to be nurses, but can't get to a nursing school. You have a dental hygienist, and Connecticut calls out oral care as being funded, rural health as part of oral care being funded. So you've got the dental hygiene preceptorships that can absolutely work now in remote learning. All of these talk about remote training, talk about the use of AR and VR in educating their physicians, whether it be GME or people who want to be in the field coming out of college. So I think that the expanse here of shortening the space, whether it be between remote encounters, physicians and patients, or between those who want the education opportunities or the training, mobile sim labs, etc. I think all of that is helped very well here. And when you wrap cyber and security around it, it's well protected and begins with trust.
Now, Rich, excuse me, Dr. Moore, you're talking a lot about innovation, and that's really exciting, especially as it relates to training the doctors and nurses that are coming through. So, Rich, I want to hear from you. Dr. Moore is talking a lot about innovation. He's talking a lot about things that are happening that are new and exciting with training our doctors and nurses, especially in the education space. But are you seeing the same thing? Is it all innovation just because of this new funding, or are you seeing infrastructure as well?
Yeah, I think the West is doing a great job on the innovation side, but I also see them very, very focused on the infrastructure piece as well, right? Again, a lot of connectivity in some of these states that I'm focused on, Montana and Idaho specifically. The connectivity is not there right now, so that's at the forefront of their minds. But again, these West Coast states are also doing some really cool stuff, like the AI-driven predictive analytic platforms, and then I really love to see how the tight integration with remote patient monitoring, right? How are we going to get more devices in the hands of folks that aren't anywhere near a hospital, right? And I love to see that across those plans.
And how do we train those people, Rich? To your point, let's give them the devices, but are they adept at using the device? Have we made it easy for them? Have we trained? Yes, there's some money out there that you can train twice a year for your RPM, but is that going to stay? I don't know. But are we ready for the uptake, right? I mean, telehealth at this point is a lot like taking your car to the mechanic and saying, look, I've known this car for a long time. I've had this car since I was a kid. It's running a little rough. I need to know why it's running rough, what it's going to cost to fix it, and how long is it going to be here. And by the way, you can't touch it. So that's kind of what we have for telehealth. So we need those tools there. But great point. Are we spun up? Can we get this into the hands, and can those people that have it use it effectively?
It's a great point, Alan, because I love the car analogy. A lot of different variables, different cars on the road, right? I think even when you look down the street, there could be a brand new one, or there could be one that's older than me, right? And so I think about it the same way with devices in people's homes, right? So where is this imperative on, and who is going to be there to train them? And I think that's something that needs to be addressed either by the states or the partners they enlist to help them with these efforts, right? Because again, I don't know. I just don't think my parents or my grandparents' iPhones are like this year's iPhones, right? So how are we gonna help people bridge those gaps?
We probably have some people that can help them upgrade that. Team, I've never been so excited as I am right now, just to hear some of the things you're talking about and the future of healthcare, and how this funding is going to not only drive innovation, but support needs that have been where we've had gaps for many, many years. Let me throw it out to closing remarks, and let me turn it over to the panel as a jump ball for closing remarks.
Jim, thank you for moderating. Myron, thank you for hosting us. Rich, Maggie, it's been tremendous. We could keep going at this all afternoon. I think what sums it up for me is a quote from the Wisconsin grant that was submitted to HHS. And they say that they're looking for technology and rural health transformations to provide the right providers, empowered by the right technology, and supported by the right network. Full stop.
Yeah, I think that's a great point. And this has been a great discussion. The one thing that stands out to me is really we're the stewards of the technology and the connectivity that these health environments are utilizing. And so much of the fragmentation exists because everyone runs at the market with the next greatest thing from a vertical solution. But it's really important that we get the fabric of connectivity and these things all meld together so we can really drive a meaningful impact. Because in order to have the best network, the best device, and the best workflows are really going to come from the unification of us all cohesively working together and really trying to make sure that we're pushing the wrong players so the right players have an opportunity to work with the health systems. It's so key that those types of success criteria are defined up front and the right partners are leading the cause of change.
Absolutely. I just would like to add that rural communities should not underestimate the power of influence of their policymakers. Those policymakers can lean into this entire process and impact meaningful transformation to the rural healthcare system.
Thank you for that, Maggie. I think that's fantastic. Myron, let me turn it back over to you.
Yeah, this has been a great discussion. I think this is the wrap for today's show of Healthcare on the Move. A huge thank you to the T-Mobile team for sharing what they're seeing on the ground firsthand. It's really insightful, and I know our audience will really enjoy looking back and hopefully reflecting on this show today. If this was helpful, we would be honored if you would share this out on your channels to anyone who might benefit from this information. We're looking forward to the next opportunity to spend time with the T-Mobile team today, and want to say a huge thank you for listening, and we'll see you next time.
Healthcare on the Move isn't just a podcast. It's a movement transforming healthcare through collective wisdom and innovative thinking. Each episode challenges listeners to move beyond passive understanding to active engagement in reshaping our healthcare landscape. If today's conversation sparked something within you, share your insights, subscribe, and help us drive meaningful change. Because transformative healthcare happens when we move together.